Yeah.
Absolutely. All right.
Um, it, Welcome all to the Matrix AI seminar series. It's my honor to introduce today's speaker. We have Dr. Irene Chen, who is currently a postdoctoral researcher at Microsoft Research. Her research centers on machine learning methods for improving clinical care and making it more equitable, which is really at the core ethos of what some of the things we are doing at Matrix. So really excited to have her here today. And more exciting news for Irene is that she is going to become an assistant professor at UC Berkeley and UCF's Computational Precision Health Program in July 2023, very soon. And her work centers on machine learning methods for improving clinical care and making it more equitable, as well as auditing and addressing bias in algorithmic models. And her research has been published in several premium machine learning conferences, such as NeurIPS AAAI, and her work also has been published in medical journals such as Nature Medicine, Lancet, Digital Health, and several others, and covered by media outlets including MIT Tech Review, NPR, and Stat News. She has been named a rising star in EECS by UC Berkeley, Harvard, and University of Maryland. No small feat. And she has received her PhD in EE and computer science from MIT and her ABNSM in applied math from Harvard. A pleasure to have you here with us today, Irene. The floor is yours.
Hello, everyone. I'm delighted to be here. And as I was just we were chatting a little bit before things starting, it sounds like this is a tremendous new program that's sort of bridging across different types of expertise skills, and then you'll soon find that this is exactly the kind of skill and the kind of researchers that we need for the future of AI in health. So I'm very excited to be here. I have about let's say 45 minutes of material plan. Let's aim for that. And then feel free to jump in with questions but we also have time at the end, since I know that jumping in with questions virtually may be a little challenging, especially given the setup. So we'll definitely make sure that we have time for questions at the end. And then lastly, before we get started, I wanted to give a special shout out to all of my collaborators listed at the bottom, without whom this research would not be possible. So I don't have to tell this crew, but right now, machine learning for healthcare has this fundamental opportunity. Learning has this fundamental opportunity to fundamentally change healthcare. We may be interested in things like building algorithms to develop better clinical interventions, or just understanding human health in a more consistent way. Either way, right now we have a really prime opportunity because the field is experiencing a time of great change and progress. On the left, we can see a few different icons that only represent just a few of the variety of data modalities that are now available. These data sets can come in different sizes, different kinds of features. My research focuses primarily on that top left, electronic medical records, but I want to call out that there are a variety of different other types of health data that are now being digitized and collect more and more frequently. This availability of data and more advanced machine learning methods has led to an increasingly large number of FDA-approved medical applications as well. So here we have a bar chart. On the x-axis is the year. On the y-axis is the number of FDA-approved AI and ML-enabled medical devices. So nothing, a few maybe, and then bam, off to the races. This last bar I want to call out is actually only available, the data is only available for the first half of 2022. So 91, and you can imagine if we doubled it, thinking that the second half is sort of more in the ballpark the same as the first half, we would imagine it sort of just takes an exponential curve. With all of these advances in deep learning, all of the available data, there are still a few technical and data challenges that are specific to healthcare. For a few reasons. One is that the data itself can often be limited and sparse. I just waxed poetically about how we have all these different modalities and all this different health data, but the truth of the matter is, once you narrow it down to the type of data you're most interested in and the kind of population you're targeting, maybe people who have diabetes and specifically aren't reacting well to this medication, the data set that you're looking at might often be quite small and sparse. So in one study, a well-cited type 2 diabetes prediction model over 50% of the patients had over 50% of their data missing, meaning that there's a lot of missing data that goes on. We've also started to learn that this missingness is usually not at random at all. Researchers have found that the time that the lab test is ordered, for example, is more important than the lab test value itself. This kind of makes sense in that, if someone is getting a lab test done in the middle of the night, it's generally because the nurses or the clinical team feel like this person needs to be be monitored all the time, and therefore the ordering of the lab test, the existence of the lab test in the middle of the night, is actually telling you something more than the lab test value itself. So the missingness can have its own signal here. There is also a wide variety, a large heterogeneity in clinical protocol. So if you have two patients who have identical breast cancer symptoms, etc., depending on what hospital you go to or what geographic area they're in, or even what type of insurance they have, they could have very different clinical protocols, even for the same risk profile of patients. And lastly, healthcare is not a solved problem by any means. So if you ask 5 different doctors for the same patient, they may have 5 different opinions. And in fact, next year, we may find out that all of these opinions are wrong and we should revise them. The New England Journal of Medicine has done a meta study, and they found that 13% of medical practice papers are reversals, meaning they contradict established medical practice. My research focuses on questions of equity and fairness. So when we bring those questions into the picture, we start to run into even more technical and data challenges. For one thing, and I just want to get this off the bat, healthcare as it's currently practiced is not equitable. Black women in New York City, for example, have much worse rates for maternal morbidities, even after adjusting for socioeconomic status. So this is comparing Black mothers and white mothers. The data we choose to collect can be skewed as well. Genome-wide association studies, or these large data sets that are prized for how representative and how much they're going to improve population health, have been found to have large selection bias issues. In 2008, researchers found that 96% of the participants in all of the GWAS data sets are of European descent, which is pretty bleak and not at all representative of the type of people we have in the world. Since then, that was in 2008. Since then, I've seen some sort of preliminary studies that they've been able to, through aggressive data collection techniques, been able to lower that to 80% of all participants in GWAS data sets are of European descent. But as you can see, we still have a long way to go. And the reason that the data that we collect is important is that different populations of people can actually face differences in data distribution. So, as a very clear example, heart attacks present differently for men than for women. Therefore, they may affect what treatment they receive, how they're triaged. It's important that we're able to collect data on all of these populations to better learn cases where the population's symptoms and care may differ. So we have a biased existing healthcare system. We're collecting biased data. Is it any wonder then that we're starting to have examples of algorithmic bias, cases where the algorithm seems to be showing clear bias for or against different subpopulations? My research focuses on this entire machine learning pipeline. So, it is it is important for me. Oftentimes we start at the end. So this post-deployment consideration, these bias audits, I think that are very common right now. Thinking about how can we take an existing algorithm and figure out if it actually is fair or biased in the first place. However, and this is maybe something I want the entire, the entire audience right now to think about. I challenge you to think about how the earlier stages of the pipeline could vary. So starting with problem selection, there exists populations and diseases that are currently understudied by the existing healthcare literature, much less the existing machine learning for healthcare literature. How can we broaden the types of populations and diseases that we are focusing on? Once we've identified a problem, there's data collection. The way we collect data, the populations we include, how kind of criteria we choose and not choose to admit actually, are all must be carefully considered. Then we get into outcome definition. So in machine learning, we often have X's and we have Y's. The choice of label, the Y value, can have large effects on the problem formulation. For example, something like diagnosis label can have its own sources of noise and bias because you're relying on the patient being diagnosed and coming into the healthcare system and then being logged properly to use as your Y value in this prediction task. And then lastly, algorithm development. Um, Algorithm development has sort of received a lot of effort and attention recently, in addition to post-deployment considerations. I'll just say that sort of building an equity-aware algorithm is of large interest to the community and something we're still trying to figure out best practices for. So today I want to talk through two projects. One is going to be looking at how to build algorithms that account for differences in access to care. We can think of this as sort of roughly corresponding to the algorithm development stage in the earlier slide. Specifically, I want to talk through how we can take for example, of heart failure, think about disease phenotypes and how access to care may be sort of confounding some of the data and how to correct for that. Next, I want to think about an example of what does it mean to pick the right problems? What does it mean to use machine learning to improve equity, to increase equity? And I want to look at specifically the question of intimate partner violence and how we can help doctors start to better understand and treat patients that we might be overlooking. I also want to call out that I have a whole body of work specifically around equity audits and post-deployment considerations for machine learning. Unfortunately, I won't have time today to talk about it, but I want to sort of give a general plug in case you're interested in diving into a little bit more. There's a large amount of stuff that I've done, and it could be of quite interest, and I'm happy to come back and do another talk about all of that. But first, we want to dive into a question of how to build algorithms that are equity aware. So rather than waiting for after a model is built and then debugging it afterwards, can we build these principles directly into this algorithm? In this part of the talk, I'm going to walk through an example of building an algorithm that can learn differences in access to care. Specifically, we're going to be focusing on disease subtyping models, and through a better algorithm, which has some nice theoretical guarantees, I'll show that our model actually works. And we verify this on real clinical data that we gathered from a hospital in downtown Boston. So one of the ways that I like to think about systemic health disparities is breaking down what kind of disparities there are. For example, there could be disparities in access to care. There is increasing amount of evidence that hospitals in America are closing, particularly in rural locations. People have to drive over an hour to the closest place to where they can receive medical care. There's also large differences in insurance coverage. I happen to have pretty good insurance, and therefore, if I feel sick or if I have any kind of symptoms, I go in immediately and a doctor can help me. If you don't have great health insurance, you may be reluctant to come in because of the financial burden. Or you might actually be more skeptical of the healthcare system in general. Maybe you're lacking trust in the system, which would lead to lack of medical adherence as well. You're less likely to follow the protocol that a doctor gives you. Today, we're going to be focusing on disparities in access to care. I want to call out two other disparities that I think are quite interesting as well. One of them is the fact that you can get different treatments for the same condition. So two people who have the same exact condition could walk in and get different treatments because of what the clinician believes about your pain tolerance, or whether or not they believe you about your symptoms, or whether or not they're sort of what the textbook protocol is. And then likewise, people who have different physiological symptoms, like I said, heart attacks can manifest differently for men than for women. They may receive the same treatment. They may need to receive the same treatment, but may in fact sometimes receive different treatments despite the same underlying source. And then lastly, disparities in outcome. The statistics on these are quite bleak. So things like life expectancy by race or socioeconomic status, maternal morbidity rates by race, these are all red flags that we should really be looking into, figuring out why and how we can address the fact that these top line numbers are so different. But today, we're only going to focus on disparities in access to care. So the motivation for the section is disease subtyping. Disease subtyping is a method to better understand diseases. Biologically, we may call one disease the same name, something like breast cancer, but we know now it can manifest differently and it can react differently to treatment. A famous example in breast cancer is the fact that cancer cells can grow in response to different hormones. They can grow in response to estrogen, progesterone, or a growth promoting protein that is called HER2. How many receptors the cancer cells have is very key for planning treatment and also the overall progression of the patient. Scientists and clinicians are interested in a variety of chronic conditions that have the same feature, that they develop differently over time. Despite them all sharing the same name, asthma, and autism, and heart failure all have sort of different branching phenotypes that can affect treatment, can also affect sort of how the patient is going to grow over time. We want to use machine learning to find similar patients to each other. So unlike things like supervised learning, where you're looking at a person and you're diagnosing them with a specific disease, yes, no, they have heart failure, yes, no, they have diabetes. Finding subtypes is considered an unsupervised approach. So things like clustering methods are helpful to sort of understand these patterns. We could use these findings, for example, for better understanding the disease. We could design future clinical trials, or we could we could design future clinical research, or we could screen for clinical trials. These are all things that if we better understood the disease, we would be able to tackle. And ideally, we would like to learn them from longitudinal observational data. Here we have 3 patients with one biomarker. So one biomarker is collected at different times of the day, or different times overall. And darker here means that the biomarker value is more severe. If we look at this data, A and B start pretty mild and get more severe, whereas C starts severe, very dark red here, and then gets more mild instead. If we wanted to find clusters or sort of similar patient profiles, patient A and patient B seem like they would be pretty close fits, right? And therefore, if we were to find clustering, we should make sure that A and B are in the same cluster. However, we don't live in an idealized health data setting. We don't have all the data all the time. We may not see everything. Data, in fact, can be observed only for a known interval. This is called interval censoring. Data can be censored at the beginning or the end of collection. If it's censored at the beginning, this could be because of things like insurance coverage, as I mentioned, geographic proximity to hospitals, trust and comfort within the healthcare system. If it's censored at the end, this is called right censorship, and this is sort of very common in survival analysis and maybe because of an adverse event removes a patient from the dataset collection. This could be patient mortality, or the patient leaves the study. For example, they move away and we can't collect that data from the hospital anymore. So today we're going to be focusing on the fact that these kinds of censorship, this data issue that we can't see the whole longitudinal time series, um, uh, pollutes the clustering algorithm, and therefore we'd like to develop algorithms that take that into account. Specifically, the fact that different people have different relationships with the healthcare system. So I want to call out that I have sort of centered this whole discussion on equity and fairness, but even if you are listening right now and you don't care about equity or fairness at all, this kind of censorship makes for just wrong algorithms. It can create erroneous subtyping if applied naively, and that is why we want to make sure that we at least fix some of these noise confounding factors that are in the data. So when we think about ways to learn disease subtyping, we have a few options. The first option is to manually align the subtypes through context clues or domain knowledge about the disease. This can be really tricky because clinician time is expensive and they may not even know what the true alignment of a person should be. The second option is to choose some seemingly reasonable point to align all the patients by, for example, the first hospital visit. Let's dive into that actually. So we may just ignore the fact that things could be misaligned and figure out something that can reasonably align it, we hope. Let's assume that all our time series are observed. So we have the same time series as before, and we align them based on when they're first observed. So oftentimes in the data, we'll call this time equals 0. Here, patient A, if you recall, had significantly more unseen data. There was a long gray box, but here we've sort of scooched it over and we don't see that. B had practically no unseen data, so it's less affected. C had some unseen data, so it's also scooched over a little bit. Because if you remember, A and B were supposed to be in the same subtype. They have the same mild to moderate to severe progression. However, here, if we align it by dataset entry, A and B look very different from each other. If we were allowed to slide A over a little bit to the right, we might see that A is just B with the first visits chopped off. However, if we don't allow for learning alignment, we might get incorrect subtypes. We might actually look at this and think, oh, yes, there's three types of patients. There's mild patients, there's moderate patients, and there's severe patients. This is not so helpful. We walk through a visual example of why option 2 would not work. Let's see if we can incorporate some sort of statistical model to explicitly disentangle subtype identity and alignment. So here our goal is to learn them jointly in one model. If you remember option 2, though, we're going to be able to compare against that as a baseline for our approach. At a high level, we developed a deep generative model called Sublime that learns the alignment of a patient, meaning how much left censorship is involved, as well as the subtype of the disease, meaning which disease phenotype are we looking at here. Both the alignment and the subtype are assumed continuous for the greatest amount of expression in the model. So first, we derive this graphical model. We use something called variational approximation, variational inference, to learn the data likelihood of our model. We show some identifiability conditions results for our model. And then lastly, we have these empirical results about known clinical findings and whether or not we can recover them in our model as well. So first and foremost, how are we modeling our clinical data? Well, biomarkers are measurable indicators of disease severity. We might have creatinine, glucose, and BMP. BMP is a blood hormone that's built up by your heart, that's made by your heart when pressure builds up. And we want to specifically handle irregularly sampled multivariate time series. We do that here by encoding NAND when the data is missing, and also using, later we'll see, an RNN encoder, which can use a pack and pad technique to handle the irregularly sampled part of it as well. We want to learn two things in our algorithm. We want to learn our latent subtype and our latent alignment. Subtype here, we're going to relax. So it's going to, instead of it being discrete subtypes, like 3 subtypes or 10 subtypes, we're going to learn a continuous latent space, meaning that just in general, 2 patients that are similar subtypes will sort of be projected into the same area so that they're close together. Here, our old friends, patient A and patient B, if you recall, they're from the same subtype, so we want them to be close together in the latent representation space. We also want to learn the delayed entry. So we call this the alignment value. How long did a patient wait? How long of a delay was there before we were able to collect data for each patient? We call this value delta. So we have delta A, delta B, and so on. If you remember, patient A had a longer delay in going in, and therefore we would expect delta A, the learned alignment time, to be larger than delta B. So from a data generating perspective, we get some notion of the disease subtype, some notion of the delay, and we map that into the data space of the data we observe. Specifically, we see the time, observed time, and we see the biomarkers. We see X and we see Y. So we measure the creatinine at what we think is time equals 3. But here I want to point out 2 things. One, the shape of how this disease will progress is governed by big theta, which is also related to the disease heterogeneity space Z. And then the second, the delayed entry value, that delta, is added to the observed time. So if we see someone at time equals 0, we think this is the first time we've ever seen them, so their time equals 0, but there is actually a secret delay. So maybe delta was actually 5 years. They waited 5 years before they came in. Their true disease time is actually 5 plus 0, which is 5. Similarly, if they didn't wait, they in fact came in as soon as they had any kind of disease progression at all, delta could be 0, and then any true time, we see them what we think is time 3, 3 years in. It actually is 3 years in because there was no delay when they came in the first place. So with this instantiated model, we can maximize the lower bound. Oh, sorry, I've jumped ahead of myself. So the model, as we've specified, is a nonlinear latent variable model. This is incredibly hard to parameterize or to do inference on. So what we do is we do a relaxation and we maximize the lower variational lower bound instead. And the way we do this without getting too much into it is we parameterize Q here as a tractable set of functions, and then we find the distributions that would be closest to the data distribution overall. Practically in the sort of model architecture space, this means that we use a recurrent neural network encoder. We borrow some techniques from variational autoencoders, namely that we learn the mu and sigma for the normal distribution governing Z, and then we learn some decoder that comes back out, mapping it back onto the same observed times and biomarkers. So I showed you the model, I showed you what we've sort of set up, but we're here actually for the true clinical impact. We're here for the messy, technically challenging data, as I mentioned. How does this algorithm actually work on real healthcare data? So we evaluate on a heart failure observational data set from Beth Israel Deaconess Medical Center located in downtown Boston. This is Dr. Stephen Horn, one of our longtime collaborators. And our goal here is to figure out what kind of subtypes. We've learned some subtypes, learn some disease phenotypes, and see if it seems like it's making sense. Heart failure is interesting on its own because there are 2 known subtypes of heart failure. We have diastolic heart failure, which relates to diastolic and systolic heart failure, both of which relate to ejection fraction. So ejection fraction is how much blood the heart can pump back out after it's been filled. You can imagine a low ejection fraction means the heart cannot pump out too much blood. It's sort of failing in a very obvious way. That's systolic heart failure. Diastolic heart failure is kind of a mystery to cardiologists right now in that there are other ways that could be wrong, and we'd like to better understand what's going on. So here we choose to actually learn 3 different subtypes, most because there's 2 known subtypes already, and it would be interesting to just see what that 3rd subtype would look like. So here we run Sublime, we find this latent representation space, and then we post hoc cluster the continuous latent space into 3 clusters. As we can see, there's cluster A, B, and C, and then the number in parentheses is the size, so roughly equal sizes, which bodes well. Then we would like to figure out what's going on. How do these subtypes even look like? As you saw maybe on the previous slide, we're learning all of these subtypes purely based on the echocardiogram value. So we're not looking at anything else, just the sort of the heart functionality. But we'd like to be able to describe these subtypes. And so what we do is we look at different demographic and symptomatic features across these 3 clusters. So as one example, we have 3 clusters, A, B, and C. In A, we have 600 or so people. What is the average age of people in cluster A? What is the average age of people in cluster B and average age of cluster C? Then we compare all 3 to see if that's statistically significant across clusters. We apply a false discovery correction here with a Benjamini-Hochberg correction, since we're doing a lot of different checks, since we're checking over 24 demographic and symptomatic features, and 11 of them are statistically significant, meaning that there are 11 features that sort of describe the differences between these 3 clusters. And then we report the cluster means for each feature. This is a lot of data to parse on one slide, so let me walk you through a few highlights. One is that the diastolic and systolic heart failure clusters do come back out. So here, cluster A, I'll just read some of these values to sort of make sense of this table. In cluster A, 50% of those people have diastolic heart failure. 9% of those people have systolic heart failure. So that cluster seems like it's a diastolic heart failure dominating cluster. Cluster C, 53% of those people have systolic heart failure and 6% have diastolic heart failure. So again, that seems to be a systolic heart failure cluster. Cluster B is the weird one out. It's about half, 30%, sort of equal, 30% systolic heart failure, 30% diastolic heart failure, meaning maybe it's a mix of the two. Something else is going on. I want to note that when we compare to clusters that are learned from our baselines, meaning we did a separate version of this algorithm that didn't even do alignment value at all, and then we looked at some other similar baseline methods that other people have come up with, we were not able to recover this diastolic systolic heart failure separation. So we know our method is at least confirming the existing separation of heart failure. And interestingly, another thing that jumped out is that women and obese patients also do not have even distribution throughout the clusters. In fact, diastolic heart failure, cluster A, has 70% of those people are women, meaning that there seems to be sort of a gender element of this diastolic cluster. Remember, diastolic is the type of heart failure that has high ejection fraction, so it can pump the blood back out, but something else is going wrong. Similarly, not similarly, but sort of additionally, cluster B has the highest rate of obese patients. And you'll remember cluster B is that cluster that had roughly equal rates of diastolic, systolic. It's that mix, it's that mysterious, we don't really understand this cluster. And it may in fact be that obese patients are manifesting heart failure at different rates or in different ways. This actually aligns with clinical findings from the past 5 years. So we know from clinical literature that women and obese patients may in fact manifest differently. Specifically, women have higher diastolic heart failure rates as shown clinically, and obese patients with preserved ejection fraction. So that diastolic heart failure that we were talking about, there's something going on there that they're calling a paradox or something else, where their hearts can beat fine, but they're also manifesting other heart failure symptoms. So as a recap here, we thought about access to care. We tried to figure out how it'd be confounding the data that we might be observing, and we model it as a latent variable. Then when we build a deep generative model, we are able to validate known subtypes for heart failure, and then there are also similar results in Parkinson's disease that I did not show you. And we validated this on real world data. So at a high level, I want to say that this algorithm seems to be working well, and it also is able to correct for any kind of sort of misalignment of time series data. Next, I want to talk about sort of switching gears a little bit. Instead of sort of saying in the algorithm, what are the problems with the data that we should address and correct for? What if we expanded or we moved up the data pipeline? We went all the way to problem selection and we said, what if we tackle areas that are patients that are underserved by the healthcare system right now? And specifically, women are predominantly affected by intimate partner violence at a much higher rate. So intimate partner violence, for those who don't know, is defined as the physical, sexual, or psychological violence and or stalking by an intimate partner or former intimate partner. The CDC estimates that in the US, 1 in 3 women and 1 in 10 men will be a victim of intimate partner violence in their lifetime. So it's quite prevalent, despite the fact that it is, I would say, understudied, underreported, understood. Globally, we have a huge problem. According to the UN, half of all women who are killed by their partners or by their family. And in fact, there is an opportunity here because IPV victims can come into the healthcare system very often. We know that they come in very often. They might not have a dedicated healthcare provider, but they come into urgent care, they come into emergency departments much more frequently. And with all of these machine learning advances, for example, algorithms that can screen patients with higher than human performance, the question is, can we do something? Can we, in fact, start to make a difference here with machine learning? I want to say that the number one problem, backing up, the number one problem with intimate partner violence in machine learning, at least, is the fact that our labels are pretty faulty. So this is going to that outcome definition. Specifically, the biggest barrier to early intervention is the underreporting by the patient, maybe because of economic dependency, shame, stigma, all kinds of factors. But we were able to start to take a look at and collect a well-honed data set of 1,500 patients and control patients from Brigham and Women's Hospital in Boston. So the first question is, what kind of labels should we use? We could use ICD codes. So these are diagnosis codes that are logged within the healthcare system. The problem is that ICD codes are made for billing. They're actually designed for great billing practices, and and as a side effect, we use them for our healthcare analysis. Because things like intimate partner violence are not billable, are not things that they're so important to put into the record. Oftentimes we find that basically no one has these ICD codes. Additionally, this is also based on the clinical staff assessment, which could be have a lot of false negatives. For example, people are intimate partner violence, but they're missed, or is subjective because it's based on clinical staff assessment. The next two labels are a little bit more promising. So there is a violence prevention program at Brigham and Women's Hospital. Patients can choose to enroll. So we call this patient disclosure. You receive social worker help, you can get legal help, you can get resources to shelters that are nearby. There's just a lot of information and resources available if you enroll in the program. So patients who seek that out are some sort of people that we're keeping our eye on and would reasonably think are in fact intimate partner violence victims. The last label that we chose to use was actually was labeling injuries based on radiology reports. So can we actually train these super specialized fellowship trained clinicians to be able to identify intimate partner violence just based on their radiology reports directly? Let's take a look at 2 and 3. So as I mentioned with patient disclosure, there is a violence prevention program at Brigham and Women's Hospital. We ultimately use the label, which is that did this person self-report, self-come in to the Brigham and Women's Hospital Violence Prevention Program. That's our label. Then for radiology label, we have fellowship trained emergency radiologists, and they looked at all of the different records of one person to label each one and say, okay, we're pretty sure this is it, or we're pretty sure this is not a person who has intimate partner violence, or we're not sure, and we can use that, we can update that information as we learn more about this patient. On the right-hand side, this is actually a picture of a ulnar fracture. This is one of the findings that we were sort of keeping our eye on. One of them is that when a patient comes in with an ulnar fracture, they will often say that they fell. Turns out if you fall, you will, your human instinct is to catch yourself with your hand, and if you have too much force, you might break your wrist. But it's very unlikely that you would break your ulna, which is much more likely to come from a defensive wound, so coming an attack from above that you're sort of trying to stop your arm for. And this became something that we were able to learn from the pattern, and also keep an eye out to see if we could learn other kinds of patterns that would be helpful for identifying victims. So how did our algorithms do? How did our predictions differ on these two different labels for intimate partner violence? The model performance is about comparable. These are AUC numbers, and they are quite close. So above 0.8, meaning we can in fact predict pretty well. Because the self-disclosure labels are much less time intensive, this is encouraging for us in that we can use this program ID and sort of know that we have about the same accuracy as the radiologist labels. And then what we did was actually we used this predictor and we predicted for each different visit as people come in. Because remember, people come into the system for years before they might enter the program. And we found for the patients that we were most interested in, we actually were able to detect intimate partner violence about 3 years in advance before the program entry. So this implies that there is an opportunity here for early interventions. What about clinical indicators? So before we were only looking at radiology studies. Here we can also start to fold in the diagnosis codes from the patient longitudinal records. I did just say that diagnosis codes are only for billing and we shouldn't use them, but I was more about intimate partner violence labels themselves. ICD-9 and ICD-10 diagnosis codes are very useful for all kinds of other symptoms. For example, chronic conditions that might be at higher risk, or as we'll see later, substance abuse and mental health disorders are also at high risk as well. And what we ended up doing is we could make a timeline here. On the x-axis is the years before intimate partner violence self-disclosure. So before they come into the program, can we see what the general patterns of these patients are? And on the right-hand side, that would be people, diagnoses that show up basically right before they're about to enter the program. We can see physical abuse, Batter by partner, that's that intimate partner violence diagnosis code. Unarmed fight, accident. But if we go a little bit earlier in time, we can start to see that there are other substance abuse disorders, mental health disorders, even prenatal diagnoses that we're able to learn earlier in the timeline and be able to have better understanding of these patterns. So at a high level, we can in fact identify IPV patterns, including a thing like an ulna fracture. The clinical indicators also seem to help and are able to learn different patterns that can come years before a physical injury. And in fact, these years before provide an opportunity to think about the best interventions. We want to be very careful. I want to stress this. We want to be very careful what we do use this kind of algorithm for to make sure we are being considerate to the patients, using the right kind of AI integration into the system in order to improve the patient care experience as opposed to increase stigma or sort of gummy up the clinical workflow. So that concludes the two different presentations I wanted to cover. I want to conclude thinking a little bit about how we're going to think about the future of AI in medicine. So this is from a Pew Research Center study, and the headline that was sort of everyone ran with was that 60% of Americans would be uncomfortable with their provider relying on AI for their own healthcare, meaning that patients are understandably very wary of AI entering their healthcare. Here, one of the sub-questions they asked was whether or not they think that the existing racial or ethnic bias in healthcare would improve or deprove. Would it get better or would it get worse with the use of AI? And people had all kinds of reactions. So in the blue side, 51% of people think that the bias problem in healthcare will improve because of AI. And so it says things, people had responses like, AI isn't going to have preconceived notions about patient symptoms. It will just analyze the data. Then there was another percentage of people, 15% think that it'll get worse. And sort of this is the green quote here, AI is trained on existing data sets which are already biased by the humans who made them. I'm inclined to say both, both the bias and the racial, existing bias will get better and it may get worse. And I think of my research as both sides. So this is like a glass half full, half empty approach. Yes, if we blindly run data sets on existing bias, it will exacerbate the bias, and we should be incredibly vigilant and develop tools to prevent that. But on the other hand, we have this opportunity to analyze data in a way that people who are not included in clinical trials or particularly represented in the medical space are able to be seen through their data and learned about and given better predictions and clinical interventions for that. So I'd like to go ahead and conclude, sort of challenging everyone to think about the entire machine learning pipeline. If you have any questions about the talk that you don't get to ask today, although we have some time for questions, feel free to reach out, email me, tweet me, all this stuff. I'm very available and I'd love to chat about this more. So thank you so much for being a great audience.
Thank you so much, Irene, for that really enlightening talk, and I think giving us like insight of how machine learning models and AI can help in healthcare. And you left off with a very important question, I guess, in a sense for all of us to think through. So maybe as we have audience asking us questions, I think the first one is from Stacy. You want to ask the question?
Sure. I guess could you or have you in the past used the social determinant of health codes or any unstructured clinical notes in EHRs to detect IPV?
That's a great question and actually is something that we're working on right now. So as you can imagine, social determinants of health are incredibly useful, but also incredibly important to do well and to gather in a consistent way, in a way that is helpful to patients. So right now we have a team of clinicians who are sort of coding these files for things like housing insecurity or economic dependence on their partners, things like that, to better understand different situations. It is a work in progress, and I would say it is sort of only the beginning of using social determinants of health, which are so important and so difficult to measure, to be able to improve these algorithms.
Thanks.
Thank you. We have Key. You want to ask the question?
Yes, great talk, amazing work, Irene. So I have a question for the first project. So you mentioned that you, if I understand correctly, you estimate the alignment parameter delta and the mapping to the space only using the heart kind of function related data rather than relying on some demographic or all other background information. So is that true? First, I want to make sure.
Yes. So the algorithm was learned only on values from the echocardiogram. So you think about it as heart functionality as opposed to throwing in the demographic information in there.
Got it. So my question is related with that. It seems that the alignment of a patient, it's highly related to the quality of their data, is more or less reflected in their background rather than the the medical conditions. Have you guys tried to say like I'm saying, the alignment is more related to the background information? Do you feel like it's promising to estimate the alignment parameter from the background information to further distinguish subtypes or even higher level groups of people?
That's an interesting question. One of the things we were really concerned about was learning this alignment value, not being, I guess, like relying on thinking like, oh, you're older, therefore you're probably later in your disease, when in fact you may have started manifesting heart failure the year before. And so I think because there's a lot of literature in the cardiology space about the way that heart failure may manifest, and it's a chronic condition, right? Like it takes years and years. We had patients in our data set who were there for 11 years. In order to really have a free mind about how to best sort of line these people up, and if there's any kind of delayed entry here, we did not want it to rely on that. What I'm also hearing is that, could you predict that directly from these demographic information or any kind of other features we have about the patient?
Yes, I'm asking because I'm more in the data management perspective. So we are always concerning with the quality of this data that are less reliable compared to like a big hospital. You have a continuous space to have a more kind of a better have the data in a continuous space and with better quality. But without the other kind of public available data set, this is often not the case. So I'm wondering how this kind of missing of the previous stage in like the collection of their data before we actually see the observed case, how promising can it relate to their background? That's
Yeah, I would say that it is there are some times where you might be able to predict how much missing data there is based on someone's background, but oftentimes it's really hard to estimate. I think that this
got it.
is sort of what we've learned through it is that there are a variety of different reasons why there might be missing data,
Right.
and some of them are observable and some of them are not. So I wish I had a better answer for you, but I think it is pretty variable across patients.
Thank you.
I think you're muted. Oh.
Are you muted, Dorisha?
Yes, I think I'm muted. I was telling Anthony you should unmute.
I wasn't sure what you were saying. Sorry. So thanks for this was a really great presentation. I have a question maybe on the second one regarding like intimate partner violence. Maybe some of the patients might end up going to different hospitals. Like if something happens, they go to hospital 1, and another thing happened, they go to hospital 2. And sometimes these might be in different hospital systems. So, you're not going to have access to all the EHRs everywhere. Do you think this would impact performance in terms of recall or, and do you think there's some ways to handle that?
Absolutely. So that's a huge concern. What we're finding is that patients tend to come to the same healthcare system over and over. They'll go to like the same urgent care, but they won't have like a primary care physician. So they won't have one person who's watching them the whole time, but they may have sort of a consistent relationship with the healthcare system that is fragmented because it's different people, but is in fact the whole system. That said, we're running this study out of Brigham and Women's Hospital, which is based on which is part of a 20 hospital consortium in Boston called Mass General Brigham. And therefore we're able to pull all the data from all of the hospitals. If they were to move to California, then we wouldn't be able to have any information. If they just came from California, we also wouldn't have that information. And that's the tricky part, I think, about working with these longitudinal data records that are also very fragmented, that are also really, huge, but also never big enough, that we sort of need to deal with. Your question about recall specifically, we make this prediction, and it's a probability from 0 to 1 about whether or not this person has intimate partner violence, is an intimate partner violence patient. And we can set that threshold to optimize for things like sensitivity and specificity. So in that sense, if it's more important to not have any false negatives or false positives, sort of whatever we think the clinical intervention is going to be, we can relate that. So if you're going to, take a drastic measure or something, we want to be really sure that the people that we're going to talk to or do this intervention on are probably intimate partner violence patients. On the other hand, if we're going to give them a pamphlet, or we're just saying like, hey, by the way, like we have this program, then maybe we'd be more willing to lower that threshold of converting from positive label to negative label and figuring that as well. So those are all sort of factors. I showed you the very shiny machine learning algorithm, but you could imagine there's like 2, 3, 4 times as much mind space and time spent on making sure that any implementation of this algorithm is done in a very sensitive and patient-focused way.
Cool. Thank you very much.
As I'm waiting for other questions, I have a question, Irene, in your IP. Oh, actually, Raghav has a question, so I'll let him ask.
Hello.
We can hear you. There's a little bit of an echo, but you can keep going.
Yes. Thanks for the talk. So I had a question. In slide 16, you present the censored and unobserved data, right? So one thing that I was curious was then based on the graph or the plot which you showed, like what is the data then which the model is exposed to then in that case? Or what is unobserved?
All right, so here's slide 16 again.
In this?
The data, the model only sees, let me make sure, so slide 16, this is the data as you've seen from sort of like a global view, so to speak. The model sees something closer to this data view, which is that patient A comes in and they have everything that's between these brackets that's not censored, you're able to observe. And then for patient A, they just kind of say like, okay, on September 2020.
Within the brackets, it's not censored, right?
Oh, yes, it's uncensored. Yeah, that's confusing. Does that answer your question?
No.
Okay, so the brackets are not uncensored. The gray boxes means that it's unobserved. So you could think of the brackets as marking when censorship begins and ends. And therefore the gray boxes are the data that is not observed. Then you ask, what does the model actually see data-wise? The model will see for patient A that there's some X's and Y's. So X's are the values of the biomarkers. Here you could think of it as mild, moderate, and severe. Oh, no, that's Y's. The Y's are the biomarkers. So that's mild, moderate, and severe. And the X's are the exact times. So it could be like, okay, patient A comes in January 1st, 1995, and then they came in again January 7th, 1995, all over through 5 years, for example. And then patient B may in fact have a different time scale. Oh, patient B came in January 1st, 2005, 10 years later, but the idea is that you could learn across the two patients based on this x-axis here, which is time since entry to the data set. So you'd want to think about the first time they came in and sort of how much later after that you're able to see. So a model is able to see the time they came in and then the measurements of the actual tests and biomarker measurements that are done each time that they came in.
Okay. Yeah, got it. Thank you.
Great.
Just seeing if there are other questions. Carolina?
Thank you so much for your talk. In this, close to the slide that you just presented, later you talk about a delay. Can you, I'm not sure what that delay means. Is that delay regarding the first interaction, the first claim number generated for that patient in the entire data set, or is the first diagnosis in the cardiovascular disease, which until it gets a mild diagnostic?
Yeah, that's a little unclear. Thank you for asking for clarification here. So here we have patient A, B, and C, and the delta value, this delayed entry value, merely indicates basically how long the gray box is in for the left censorship. So at the very beginning, how long is that gray box? Meaning patient A waited a while after the disease progression started to come in. So their delta value, their delayed entry value, is larger. We could think of it as 3 years, 5 years, however long. And then patient B, as illustrated here, doesn't really have any kind of delay. There's no sort of left censorship, in which case the delay value is like 0. So the delta value would be 0, and then patient C would be, somewhere between the values of A and B.
Okay, thank you.
So, other questions? Sorry, looks like there's a little bit of an echo from my side.
Oh.
I tried this. I had a question actually. In your couple of times you said you're trying to reduce the stigma. You want to be very careful how you're using these models and kind of reduce the stigma in reporting IPV. What are you doing to reduce that stigma?
Yeah, it's a really hard question. I mean, I think a lot of times we think that the math will be the hard part when in fact there's so many other things that are even more challenging. One of the things that we were very careful about in this project is to involve people who have an extraordinary amount of experience thinking about intimate partner violence beyond the AI and sort of statistics side. So we're working with, for example, Jackie Campbell, who is at Hopkins and is one of the grandmothers of domestic violence research, specifically thinking about, okay, if you could wave a magic wand and you knew what's going on, you knew this person was or wasn't an IPV patient, what would we even do with it? How would we go about improving the clinical workflow? One of the things that came through with a lot of our discussions with collaborators, et cetera, was that clinicians really care. They really want to help, but they oftentimes don't have the resources. They're not trained. This is not something that they think about that often. And unless it is staring them in their face and they have the time, they're not able to sort of do the things that they would like, the amount of care that they would like as well. So the hope is that this specific project allows us to start to peek into this process and map out what are the patterns that we're observing. Could we maybe figure these things out years in advance? And then, as you can imagine, the next super important question is, and then what? Your question was about stigma specifically. One of the things that really shocked me about working on this project was how prevalent intimate partner violence is. I think it is something that happens a lot. According to the numbers, women are more likely to be an intimate partner violence patient in their lifetime than get breast cancer or depression. The rates are staggering. And so part of reducing stigma is looking at it in the eye and saying, okay, this is the data set we have. This is what we are defining it as. It's not perfect, but this is how we're going to try to define it. And these are the results that we can find. And that hopefully bit by bit, we can better understand what patients do now, why patients are reluctant to come forward, what kinds of things patients think would help them. Even if their doctor knew years in advance, maybe they wouldn't be open to it. Or better understanding, are there different kinds of intimate partner violence, some of which get way more escalated very quickly, and some of which maybe are not as physically aren't going to show up physically as quickly as often. And so I think just even understanding these patterns is something that would be important to just understanding to better comprehending this public health concern, but also maybe starting to reduce the stigma in that sense, just starting the conversation about that.
Yeah, thank you.
I've talked to social workers who have said like, oh yeah, they don't want to tell the doctors that they're patients of intimate partner violence because they're worried the doctors will treat them differently. They're worried they'll get worse care. Like they don't want the doctors to know, which is a totally reasonable thing to also, so which we also keep in mind in terms of the last thing we want to do is have like a score go off and then patients don't have recourse to, to explain or treat it completely differently because of it. So I think we're being very careful about thinking about how to integrate this.
Yeah, I mean, I think it's really important, especially when you're designing these models in healthcare scenarios, to kind of think of that ecosystem that you're engaging in and have experts, domain experts help you. So I'm
Absolutely.
really glad to hear that. I had a question regarding the model, like which is similar to what Anthony asked. Maybe we're a little over time here, but I'll try to quickly ask and we can talk offline about it as well. So he talked about like, how the patients could be from different hospitals and there could be all these variations, but also I think the populations, right? The representative populations will make a huge difference. I think being in San Antonio, I think this, I can really see this. So is that something that you're accounting for in either of those models? And then there are some challenges that are there with the generative part of it that hospitals in general tend to have.
Oh, yes,
lot
definitely.
of,
There's a whole debate in the community right now about generalizability.
Right.
So you want to have a model that works in a hospital in Boston, and then maybe it would work in San Antonio, and you could share our findings and
Right.
improve the world outside of just this one hospital. What we are finding though is that when you try to move a hospital directly, one, it doesn't work, shocker. And then two, if you try to find something that worked on both hospitals and you only learn, let's say, the physiological things that are going on, you end up sacrificing some model performance actually. And this is kind of interesting because it turns out hospitals have very specific indicators, things like the nurse protocol or the way that the doctors write their notes or sort of like different idiosyncratic things to that hospital, that if you tried to strip all of that out and make an algorithm work across different things, it would, everyone suffers as a result. And so the model that we're starting to go with is something along the lines of like pre-train and then fine tune it on a location and being able to show that. So step one of this process is just benchmarking, do we do really poorly on other hospitals and by how much? And maybe this should be a cautionary tale to people trying to deploy across many hospitals. And then the second question is, to what extent are we okay with models that are designed explicitly to only focus on the physiological things and generalize well? Is there any drop in performance, and how would we go about measuring that? And then the third step would be, okay, how would we do this pre-train and fine-tune method? And is that better than the things that we've benchmarked in 1 and 2? So those are all sort of ongoing discussions in the field. I challenge everyone here to think about them. And if you want to work on them, you should go for it. And hopefully we'll have a better sense of how to share these findings across different things. To say nothing about questions about data sharing and patient privacy and all of that. That's like a whole other hour. But yes, it's definitely a top concern right now.
Thank you so much, Irene, for sharing this exciting research with us, and wish you all the best in your new role.
Absolutely.
And we hope to have you here in San Antonio soon.
Thank you so much for the great questions, everyone. It was so exciting to share my research with you.
Okay, bye.
All right, bye.